The broadcast is now starting. All attendees are in listen.
Today we are going to discuss about the hip joint. Hip joint is quite similar to shoulder joint in a way that it is also a multi-axial joint and a ball and socket variety of synovial joint. But in the shoulder joint, there was lot and lot of mobility possible and stability was quite less. It was more prone to dislocations. As compared to shoulder joint, hip joint, mobility is definitely there, but not as much as in the shoulder joint. But stability is much more as compared to the shoulder joint. It's a multi-axial joint, that is, the movement is possible in indefinite axes. Many axes, movement is possible. It's a synovial joint of ball and socket variety. The articular surfaces in case of hip joint are contributed by two bones, femur and the hip bone. The head of the femur, which forms more than 2/3 of a sphere, forms the articular surface from the femur. In case of shoulder joint humerus, head of humerus was just 1/3 of the sphere. But in this case, it's 2/3 of the sphere. So obviously, it's going to be contribute to much more stability. This is a posterior view of hip bone. This is the iliac portion. This blue one is the ischium and red one is the pubic component. This is the acetabulum. There is a acetabular fossa in the center, and all around this acetabulum is a lunate shaped structure. If you look at this, acetabulum is contributed by all three components of hip bone. Ilium also contributes to it. Ischium also contributes to its view structure, and red one, the pubic component. So in this lunate surface, half-moon shaped surface with a gap inferiorly. This surface is the articular surface. The fossa present in this region, which we name as acetabular fossa. This is non-articular. So, head of the femur articulates with this lunate or half-moon shaped articular surface of the acetabular. So, two articular surfaces, head of femur and lunate surface of acetabulum. The acetabulum almost entirely encompasses the 2/3 of the sphere of the head, that is hemispherical head of the femur, and thereby it contributes substantially to the hip joint. As far as the non-articular acetabular fossa is concerned, that contains loose connective tissue. The articular surfaces are covered with hyaline cartilage. So, head of femur is also covered by hyaline cartilage, except for a small fovea in the head of the femur. Rest whole of this head of femur is covered with articular cartilage, which is hyaline in nature. In the acetabulum, the lunate surface is covered with hyaline cartilage. So, this lunate surface only is covered with hyaline cartilage, not the non-articular acetabular fossa. What are going to be the ligaments in relation to the hip joint? The stability of the hip joint is not only dependent upon the congruence of the two surfaces, that is head of femur and the lunate surface of acetabulum. Head of the femur forming almost 2/3 of a sphere, and the lunate surface completely encircles it, encompasses it completely to provide stability. Apart from that, the ligaments which are going to contribute to the hip joint are capsule of the hip joint. Capsule as the fibrous capsule as is present in any other synovial joint. So, hip joint also has a fibrous capsule. Inside lining the fibrous capsule is the synovial membrane, which is a typical feature present in case of synovial joints. Then, the lunate articular surface of the acetabulum is deepened further by presence of a fibrocartilaginous rim, which is acetabular labrum. Like there was glenoid labrum in case of shoulder joint, which was deepening the shallow glenoid cavity in case of shoulder joint, so that to provide some stability. Similarly, acetabular labrum, which is a rim of fibrocartilage, which is enclosing all around the margin of the lunate articular surface, thereby deepening it further. We've seen that the lunate articular surface is deficient inferiorly. So, in that region, this acetabular labrum continues as transverse acetabular ligament. Then, the head of the femur had a depression, the fovea, in which is the attachment of ligament of head of the femur or the ligamentum teres. Then, three very important ligaments coming from the three different components of the hip bone to femur, which again provide stability to the hip joint. Iliofemoral, that is coming from the iliac component of the hip bone to femur. Pubofemoral, coming from the pubic component of the hip bone to the femur. And ischiofemoral, coming from the ischium component of the hip bone to the femur. So, all these ligaments, namely capsule, synovial membrane, acetabular labrum, transverse acetabular ligament, ligamentum teres or the ligament of head of femur, the iliofemoral ligament, pubofemoral and the ischiofemoral ligament are surrounding the hip joint. Innermost amongst these is the acetabular labrum. This is the lunate articular surface of the acetabulum. This acetabular labrum is basically a rim of fibrocartilaginous tissue or the fibrocartilage, which is enclosing this lunate articular surface like a collar. Inferiorly, this lunate articular surface was deficient, so this rim of fibrocartilage bridges across this acetabular notch as a transverse acetabular ligament, thereby converting this notch into a foramen. So, there is a fibrocartilaginous rim, this enclosing the lunate acetabular surface like a collar, and inferiorly it continues as transverse acetabular ligament. The ligament of femur, ligament of head of femur, is basically a flat band of delicate connective tissue. It attaches at one end to this depression or the fovea on the head of the femur. Other end of this goes and attaches to the acetabular fossa, the transverse acetabular ligament, and the margins of acetabular notch. So basically, this head of femur having this fovea in which this ligament is there, the ligament of head of femur attaches from this fovea to the transverse ligament to margins of this acetabular notch, thereby helping in further stabilizing the joint. This is a flat kind of connective tissue, and it also carries a very important artery, which is a small branch of obturator artery, and this small branch of obturator artery, which is traversing through this ligament of head of femur, contributes to the blood supply to the head of the femur. This is especially very important, more so in case of young children, where the other cruciate and the trochanteric anastomosis, the vessels can't reach this terminal portion because of the presence of epiphyseal cartilage. All of you know it, that cartilage is a non-nervous, non-vascular tissue. So this portion of the head of the femur receives the blood supply to the small branch of obturator artery, which is traversing through this ligament of head of femur. Now, external to this acetabular ligament and the ligament of head of femur is presence of the synovial membrane. Synovial membrane is a characteristic feature which provides lubrication, avoids friction in any synovial joint. The synovial joints are highly mobile joints. Synovial membrane of the hip joint, it attaches to the margins of the articular surfaces of the femur as well as the acetabulum. This synovial membrane, which is attaching all around this margin of the head of the femur, outside this articular cartilage, and to the acetabulum. Not only this forms a tubular covering around the ligament of head of femur, and it lines the fibrous capsule of the joint from the inside. So, innermost are the two articular surfaces, that is lunate and the head of the femur. These articular surfaces are covered with the cartilage, the hyaline articular cartilage. Then, external to this lies this synovial membrane, which is covering, and it is all around this inside. So, it is basically covering the inside of the fibrous capsule, and it is attached to the margins of the articular surface of the femur, margin of the articular surface of this lunate surface of the acetabular, which is the articular surface, and extending to this lies the fibrous capsule. From its margin to the head of the femur, its attachment, this synovial membrane covers the neck of the femur before it reflects back onto the inner aspect of the fibrous capsule. Thereby, over here it forms a double layer. It's attached here to the margin, then it goes back around the neck of the femur and then reflects back so that it lies the inner margin of the fibrous capsule. External to the synovial membrane lies the capsule of the hip joint, fibrous capsule of the hip joint. It's very strong and thick. Obviously, all the time human beings are standing, walking, running. So, the weight, the fibrous covering of the hip joint requires to be very strong and thick to provide stability and support to the joint. This is the fibrous capsule. Medially, it attaches all around the margin of the scapula. That is the lunate surface all around its margin. Inferiorly, that was sufficient, the lunate surface, so it attaches to the transverse acetabular ligament, and around the margin, it's coming in close relation with the operator foramen, so around the adjacent margin of the operator foramen as well. So, fibrous capsule is covering all around the margin of the lunate articular surface, transverse acetabular ligament, and adjacent margin of operator foramen. Laterally, the femoral attachment of this fibrous capsule is onto the intertrochanteric line from the femur. That is the line present anteriorly between the two trochanters, the greater and the lesser trochanters. Posteriorly, this does not reach the crest between the two trochanters, but it falls short and is attached proximally to the neck of the femur on the posterior aspect. In this picture, you can see this is the femur, anterior view, and this is the posterior view. So, anteriorly, the fibrous capsule is getting attached to this intertrochanteric line present between the greater and the lesser trochanter. Posteriorly, this is the intertrochanteric crest present between the lesser trochanter and the greater trochanter of femur. So, it does not reach this intertrochanteric crest, but it attaches to the margin of the neck of the femur. Basically, head and neck of femur are almost shaped like a light bulb. The convex big bulb with a small constriction on neck. You can compare this shape with that. So, to the neck, it's attached away or proximal from the intertrochanteric crest on the posterior side. There's a cut section through the joint. This is the head of the femur. This is the fovea to which the ligament of head of femur is attached. This is the sternum. So, all around this margin is the fibrous capsule, which is attached all around. Externally, internal to this lies the synovial membrane. External to the fibrous capsule, there are three more ligaments present, very important ligaments which reinforce this fibrous capsule externally, thereby further contributing to stabilize the hip joint. These three ligaments are namely iliofemoral, pubofemoral, and ischiofemoral ligaments. Iliofemoral coming from the iliac component, pubofemoral from the pubis, and ischio from the ischial component of the hip bone. All these three ligaments are separate and they go attached to the femur. The fibers of all these three ligaments are oriented in a spiral fashion all around the joint, and they become taut when the joint is extended. So, thereby this fibers getting out when the joint is extended. This stabilizes the joint and thereby helping in reducing the amount of muscle energy required to maintain in the standing or the erect posture. Iliofemoral ligament is one of the strongest ligaments in the body. It is also called ligament of wedlock. It is supporting the hip joint from the anterior aspect. It's triangular in shape. The apex of this iliofemoral ligament is attached to anterior inferior iliac spine. This is anterior superior iliac spine. This is the anterior inferior iliac spine. So, apex is attached to the anterior inferior iliac spine and to the margins of the acetabulum. The base goes anteriorly to the intertrochanteric line. So, apex on the anterior inferior iliac spine and the margin of the acetabulum close to it, and the base goes to the anterior aspect of the femur on the intertrochanteric line between the greater and the lesser trochanter. The important part about this is the part of this iliofemoral ligament attached above and below the intertrochanteric line are quite thicker than that attaching to the central portion. So, because of this ligament gives the appearance of inverted Y. If you look at this picture upside down, it's Y shaped. So, shape of this triangular ligament actually is inverted Y. The pubofemoral ligament, this is iliofemoral, it lies inferior to iliofemoral ligament. It supports the joint, the hip joint anteriorly and inferiorly. This is also triangular in shape. The base is attached medially opposite the iliofemoral. Iliofemoral base is on the femur, apex on the hip bone. And this base is on the hip bone, that is an eminence of bone present over here, which we call the iliopubic eminence, and the adjacent portion of the bone and the operator membrane. The laterally, this ligament, the pubofemoral ligament, blends with the fibrous capsule which is present internal to it, and with the deep surface of iliofemoral ligament. So, external to these ligaments is the internal to these ligaments is the fibrous capsule, and externally these ligaments are supporting the fibrous capsule, iliofemoral anteriorly and anteroinferiorly by the pubofemoral. Internal to this lies the fibrous capsule of joint. This ligament, pubofemoral, also is quite strong, and literally its fibers are blending with the deep surface of the iliofemoral ligament and with the fibrous capsule. The ischiofemoral ligament, the third important ligament present in this, which is reinforcing the fibrous capsule from external aspect, is reinforcing it from the posterior aspect. It is present posteriorly. Medially, it is attached to the ischium, just postero-inferior to the acetabulum. And laterally, this goes and attaches to the greater trochanter, and this ligament also lies deep to iliofemoral. So, pubofemoral as well as the ischiofemoral ligaments, they lie deep to the strongest ligament of the body, that is iliofemoral. So, this is going and attaching to the greater trochanter. So, it's supporting, ischiofemoral ligament is supporting the joint from the posterior side. So all around these ligaments, the iliofemoral, pubofemoral, and the ischiofemoral are running in a spiral fashion all around the joint, thereby reinforcing the fibrous capsule, thereby supporting it and providing stability to the hip joint. Now, what are going to be the relations of the hip joint? Already done the front of thigh, femoral triangle, the posterior aspect of the thigh, the gluteal region. So all these structures which are anterior are only from the anterior relation of the hip joint, that is structures present, some of the structures present in the front of the thigh, some of the structures forming the floor of the femoral triangle, and posteriorly some of the muscles coming in the gluteal region, lying deep to the gluteus maximus. So let's see the relations of the hip joint. This is the anterior view of the front of the thigh, and this is the hip joint. So anterior relations include the muscles forming the floor of the hip joint, that is iliacus, the psoas major, and pectineus. Adductor longus comes further medially, so it's not coming directly in relation to the anterior surface of the hip joint. Along with that, the structures lying over here, that is the femoral vessels and nerve, femoral nerve, artery, and vein, they are present as content in this region of femoral triangle. So they also form the anterior relation of the hip joint. Apart from that, one muscle of the front of the thigh, that is the rectus femoris component of quadratus femoris, also comes in anterior relation. So anterior relations of the hip joint include iliacus, psoas major, pectineus, rectus femoris, femoral artery, femoral vein, and the femoral nerve. The posterior relations of the hip joint are the structures present deep to gluteus maximus in the lower portion. Upper portion, the gluteus medius present over here, or always minimus, they will not come in this posterior relation. So lower part of these muscles, namely the piriformis, the obturator internus with the two gemini, and the quadratus femoris. So piriformis, obturator internus tendon, with superior gemellus, inferior gemellus, and quadratus femoris. They are going to the greater trochanter arising from this sacrum, etc., and going laterally. So from the hip bone to the greater trochanter, they are covering the joint posteriorly. So they are forming the posterior relation of the hip joint. As far as the superior relation is concerned, this is the tabular cavity, which is the lunar surface. So above this is the attachment of reflective head of rectus femoris, and between the inferior and the anterior gluteal line is gluteus minimus. So these two muscles, the gluteus minimus and the reflective head of rectus femoris, will form the superior relation of the hip joint by virtue of their attachment on the hip bone superior to the acetabulum. The inferior relation is formed by two muscles, the pectineus. Pectineus was forming anterior relation as well and the inferior relation as well, because pectineus is present at the floor of the femoral triangle. Then this goes from pecten pubis, this goes down and attaches onto the pectineal line on the femur. So this is coming in the inferior relation as well. Obturator externus muscle, which arises from this obturator foramen of the hip bone, on the external side all around with obturator membrane, and from this attachment it goes and attaches to the trochanteric fossa of the femur. So it's lying inferior to it. So that's why it forms the inferior relation of the hip joint. Two muscles forming the inferior relations, obturator externus and pectineus. There's a cut section through the hip joint or through the gluteal region, in which you can identify the relations of the hip joint. This picture you can even use for structures under cover of gluteus maximus muscle. This is the right hip joint. This is the unit articular surface of the acetabular. This is the non-articular acetabular fossa. This is the ligament of head of femur attaching to the margins of this unit articular surface and to the transverse acetabular ligament. This is the iliopsoas tendon, psoas major and iliacus. They are separated from the hip joint by a bursa. This is the anterior view. This is the posterior aspect. This is the superior aspect. This is the inferior aspect. So in this, you can see the relations of the hip joint. Superiorly will lie the gluteus minimus muscle and the reflected head of rectus femoris muscle, which are attaching to the hip bone just above the acetabular. Inferior relation is formed by the obturator externus muscle, mainly the pectineus, coming at the junction of anterior and inferior surfaces, thereby forming double relation with the hip joint, that is anterior relation as well as inferior relation. This is the anterior aspect of the hip joint. So structures forming the anterior relation of the hip joint include the rectus femoris muscle, the iliopsoas, and the pectineus. Along with that, the femoral artery, femoral vein, and femoral nerve. So all these structures, the rectus femoris, iliacus, psoas major, pectineus muscle, femoral artery, femoral vein, and femoral nerve will form the anterior relation of the hip joint. Posterior relation of the hip joint is going to be formed by some of the structures under cover of this big muscle of gluteal region, gluteus maximus. Gluteus medius and minimus are of the middle level. So posterior relation is formed by the piriformis muscle, the key muscle present in the gluteal region. Then the tendon of the obturator internus with two gemini, gemini inferior and gemini superior. And then below that, the quadratus femoris. So piriformis, gemellus superior, obturator internus tendon, gemellus inferior, and the quadratus femoris will form the posterior relation of the hip joint. The blood supply to the hip joint is going to be derived from the multiple vessels which are present in this region. We already discussed about the trochanteric anastomosis, which is formed by the lateral circumflex femoral, medial circumflex femoral arteries and contributed above by the superior and the inferior gluteal arteries. So these are surrounding all around this femur and giving the blood supply to the hip joint. Then there is a branch of obturator artery which is traversing through the ligament of head of femur. Small branch of obturator artery which supplies this much portion of the head of femur also contributes to the blood supply. So, the blood supply to the hip joint is by this trochanteric anastomosis, that is branches from lateral and medial circumflex femoral arteries, which are branches of profunda femoris, which in turn is a branch of femoral artery. Then branches of the superior and the inferior gluteal arteries, which are branches of internal iliac artery, that take part in anastomosis out. Then a branch traversing through the ligament of head of femur, a small branch of obturator artery. So, to make the arterial supply to the hip joint receive very rich blood supply from all these arteries, namely medial and the lateral circumflex femoral artery, obturator artery, the superior gluteal artery, and the inferior gluteal artery. The nerves, it's this Hilton's law. Whatever nerves are supplying the muscles acting on the joint are going to give articular supply to the joint as well as to the area of skin above that region. So, whatever nerves are present in this region are going to give the nerve supply to the articular branch to the hip joint. We have seen the quadratus femoris, the superior gluteal nerve, inferior gluteal nerve, then the obturator nerve supplying these muscles present over here. So, all the nerves are going to supply the hip joint. The femoral nerve gives articular branch to hip joint via nerve to rectus femoris, which is crossing the hip joint. Then branch from obturator nerve, a branch from nerve to quadratus femoris, which is a branch of sacral plexus, a twig from the sciatic nerve, which is present posteriorly in the gluteal region, a branch from the superior gluteal nerve. In case the accessory obturator nerve is present, that will also give an articular branch to the hip joint. What are the movements possible at the hip joint? It's a multi-axial joint, so multiple axes of movements, indefinite axis of movement is possible. Let's see what all movements are possible in case of hip joint. The axis of movement generally passes through the center of the head of the feet. Flexion and extension is around the transverse axis. Flexion of the hip joint is when you bend the hip joint and take the thigh, front of thigh towards the anterior abdominal wall. Extension is when you take the thigh backwards, as in walking or standing from the sitting position. Abduction is when you take the thigh away from the trunk or laterally from the trunk. And adduction when the two thighs come in opposition with each other. Adduction and abduction take place in the anteroposterior axis. Then there is a medial rotation and lateral rotation occurring at the vertical axis. Medial rotation is when you move the hip joint medially towards the medial side, that is, the great toe starts moving medially. And lateral rotation is opposite. Both these movements occur around the vertical axis. What are the muscles which are producing these movements? Flexion is anteriorly, so whatever muscles are causing anteriorly will cause flexion. Extension is the posterior movement. Adduction medially and abduction lateral movement of the limb. Then flexion, iliacus, and psoas major, the rectus femoris, pectineus, sartorius, and adductor longus. Extension is by the gluteus maximus, which is the strongest extensor of the hip joint, and the hamstring group of muscles, that is muscles present in the posterior aspect of the thigh, that is semitendinosus, semimembranosus, biceps femoris, and the hamstring head of adductor. Adduction is by all the adductor group of muscles, adductor longus, adductor brevis, and the adductor component of adductor magnus. Along with that, a medial muscle present gracilis, and Heptane also contributes to some extent by adduction by virtue of its position medially in the front of thigh. Abduction by gluteus medius minimus, tensor fascia lata, and sartorius. Medial rotation of the hip joint is by the anterior fibers of gluteus medius and minimus, the tensor fascia lata, and to some extent the adductors. Lateral rotation, all those top muscles present in gluteal region under gluteus maximus, namely the operator internus with two gemini, operator externus, quadratus femoris, piriformis, and gluteus maximus. Circumduction is combination of all these movements in which you can move the limb in all directions. So all these muscles in varying stages of circumduction will contribute to the circumduction movement. Of course, the circumduction in case of hip joint is not possible to that much range as in shoulder joint. Obviously, this hip joint is much more stable as compared to the shoulder joint, and it's supported by very strong ligaments. Iliofemoral, pubiofemoral, ischiofemoral. So all these ligaments support the joint a lot. But because of the support and providing stability to the joint, the range of movement of circumduction is restricted. What are the clinical aspects of diseases of the hip joint, or the clinical anatomy, or the applied anatomy? The neck of the femur, I told you can compare the shape of the head and neck of femur with a light bulb. The neck of the femur is inclined at an angle with the shaft, and the angle is almost 160 degrees in young children, and by adult life it reduces to 125 degrees. If the angle is increases, it's called as coxa varica. That is increase in this neck shaft, and it occurs in CDH, or the congenital dislocation of hip joint. The decrease of this neck shaft angle is coxa vara, and it occurs in fractures of neck of femur. It occurs when neck shaft angle is diminished, and which is normally 125 degrees, and if it reduces less than 125 degrees in adults, this condition is called coxa vara, and more so seen in fractured neck of femur. In case of congenital dislocation of hip joint, which is more common in girl child, the femur head gets dislocated and it lies on the gluteal surface. So, neck and the shaft angle is increased, and this condition is called coxa vara. Since the femur head is dislocated and lying on the gluteal surface, adduction is limited, the gait is legit, and the Trendelenburg's sign is positive. This is the normal angle which ranges from 120 to 135 degrees and average being 125 degrees in adults. In coxa vera, this angle is less than 120 degrees. That is in fracture neck of femur, it becomes like that. And this angle neck which increases more in adults if it's more than 135 degrees, that's called coxa vera. The fracture neck of femur that can be subcapital, cervical or basal. Subcapital just under the head of the femur, generally intracapsular only because the capsular attachment is still the intertrochanteric line in crest. It occurs more commonly in elderly people due to osteoporosis or indirect violence, etc. So, slight tipping causes forced medial rotation of the hip joint and the leg during the fall, and this can lead to avascular necrosis of the head of the femur for the reason that the blood supply to the head of the femur and the hip region, that is hip joint, is coming via all those anastomosis. So all those vessels can get torn, leading to necrosis of the head of the femur. Cervical, if the fracture is cervical in the middle of the neck, or basal when it occurs near the trochanter, greater and the lesser trochanter. As far as the young children are concerned, in which the epiphysis of the head has not fused as yet. So what happens? The epiphysis of the head of femur is supplied by a small branch of obturator artery which traverses along the ligament of femoral head, and this supplies this region. The upper part of the neck keeps on receiving profuse blood supply from this trochanteric anastomosis, from the medial circumflex, lateral circumflex arteries, etc. And these spears to the capsule and ascend in the neck deep to the synovial membrane. As long as that epiphyseal cartilage, which is non-nervous, non-vascular, remains, so especially in young children, there is no communication between two different sources of the blood. So in young children, if there is fracture neck of femur, ischemic necrosis of the femur gradually takes place. But in adults, after the epiphyseal cartilage has disappeared, the anastomosis between two sources of blood supply is established, and the blood supply to this head and neck of femur becomes safer because of the anastomosis. Osteoarthritis is a disease of old age. Basically, it causes painful and limited movements because of the presence of osteophytes at the articular ends of the hip joint. In case of arthritis of the hip joint, tenderness of the head of the femur. Tenderness is on palpation, the person feels pain. Tenderness of the head of the femur is there in arthritis of the hip joint, which one can examine. Head of the femur, the part of the head of the femur that is not intrascapular, can be palpated in the anterior aspect of the thigh, anterior to inguinal ligament. At the midpoint of the inguinal ligament, one can palpate the pulsating femoral artery. So, just lateral to this femoral artery lies the head of the femur, that part which is not within the acetabulum. So, if one presses upon the femoral head and if the person feels tenderness or pain, that means, that indicates that there is arthritis present in the hip joint. Perthes disease is another clinical aspect in which the avascular necrosis of the head of the femur in children occurs due to the trauma. Hip joint as well as the knee joint both receive articular nerve supply from the femoral nerve and the obturator nerve. So, in diseases of the hip, the pain may be referred to knee, and in case of diseases of the knee, the pain may be referred to the hip joint, and this is called referred pain. This is X-ray of the hip joint, right hip joint. This is the hip bone. This is the obturator foramen. This is the ischiopubic ramus. This is the acetabulum. This is the head of the femur. And this you can see a small depression, the fovea, for the ligament of head of femur. This is the neck of the femur. This is the greater trochanter. And this is a lesser trochanter. So it's anteposterior view of the right hip joint. This is the anti-inferior iliac spine. Shenton's line is a curved line in the radiograph where the upper border of obturator foramen is continuous with the low margin of neck of femur. This is the obturator foramen. So its upper margin becomes a continuous with the low margin of neck of femur. If it's continuous, and if this continuity is broken, that means there is some fracture neck of femur because this continuous line is not seen. This is the Shenton's line. Trendelenburg's sign, which we already discussed in the last class as well. It is seen in case of paralysis of the gluteus medius and minimus or damage to the superior gluteal nerve. It is also seen in congenital dislocation of hip joint, and in some cases if the person can walk in case of fracture neck of femur. So normal walking is possible because of the abductor mechanism of the gluteus medius and minimus. So when the person is walking, normally the foot, unsupported foot, when the foot is off the ground, that side of pelvis is raised up because of the strong abductor mechanism of gluteus medius and minimus. If these are paralyzed, or in case of fracture neck of femur, or in case of congenital dislocation of hip joint, so what will happen is this abductor mechanism does not take place and the unsupported side of the pelvis droops down when the person tries to walk. That's all for today. Any questions?